So let's look at a case and really look step by step at how we will manage these sort of single tooth cases first of all, and really understand some of the biology principles and the clinical principles that we have to employ when managing these cases. We look at this case here. It's not a particularly easy case. You can see that the patient has not the best dentition, and we have some problems that we have to look at. It's a situation where the patient was referred to us after having lost a tooth, which was previously a post-crown with an endodontic failure and I think a root fracture. The patient, unfortunately, was prescribed a number of courses of antibiotics before the tooth was extracted, and so there was some considerable damage to be expected to the bone as the infection was allowed to progress. Eventually, the tooth was extracted and the patient was sent to me some weeks after the extraction, and the patient had a provisional denture made by the general dentist. And if we look at this case, we can see that now we're seeing a case that we can learn something from, because it's not a simple case. This is a case with triangular teeth, with a thin biotype, with a very prominent root architecture. These are the sorts of challenging patients for us in the aesthetic zone, and these are really the cases that we learn from. So when we look at the patient closely, we can see that, well, we already have some problems to deal with, that we're missing some papillae because we've got triangular teeth, and you can see that the contact point between the centrals, if we had a tooth there, is going to be more coronal than the height of the papilla, and this is because of the triangular nature of the teeth. The mesial papilla of the lateral incisor is already more apical than on the right side. And the tooth is rotated and mesially inclined, which means that we'll have a little black hole there. And unless we orthodontically correct that, we really aren't going to be able to manage that effectively. So let's look at some of the things. We've got hygiene that's not great. We've got a high lip line, which is always going to be a challenge for us. Even though the patient doesn't seem that concerned about aesthetics, we know that once we've restored the case and the patient spent money on his treatment, he's going to be more concerned about his appearance than he was when he came in. We see that they have a thin scallop biotype, prominent root architecture, as we've said, triangular tooth form, and that we have a papilla on the mesial of the upper left lateral incisor that's already compromised. We have a rotated and angled tooth, and we have a large volume of bone and soft tissue missing, which is evident from the photographs, particularly from the diagonal views, which show this broad U-shaped defect, which is more difficult to manage than a narrow one. On a plus side, we have a low aesthetic demands from the patient, but that really doesn't factor in that much, because we know that once we start to treat these patients, their dental IQ always lifts and they start to become more demanding, and certainly with a high lip line, we need to get it right. So let's look at what we do. Having a look at the patient, we always do the same sort of diagnostic steps. Now, of course, you take all the necessary radiographic and other examination that you need to do, but from a treatment planning perspective, we do a wax up. We wax up the tissue that's missing, and we wax up the tooth to the contours that we think we want to do. We create a provisional restoration, and we like to use a Rochette bridge wherever possible, because it's easy to remove and replace. We can cement this with a resin-modded eyeglass ionomer such as Fuji 2LC. It's very simple, without etching and bonding, and it makes it very simple to pop these things on and off as we need to, as we treat these more complex cases. We can also use a removable denture in this case if we don't have space in the occlusion to put the metal wings on the adjacent teeth. But you have to design your denture to make sure that it doesn't put any pressure on the soft tissue and is well supported by the adjacent teeth. You can have a surgical template made, and the important key aspect of that template is to define where your final gingival margin is going to be, because that's where you can, that's the reference point to determine the positioning of your implant. So then we come to the case. We open up a wide flap because we know we have to graft in this case, because we saw there was already a large defect, and we can use releasing incisions, typically remotely from the site. If we're going to do any kind of surgery in the aesthetic zone today, we work with magnification and microsurgery, which reduces the amount of scarring and really enhances the aesthetic outcomes. We work very precisely and with delicate management of the tissues. And you can see in this case we've done a sulcular incision with some vertical releasing incisions distals to the adjacent teeth. We've done a palatal crestal incision, which is because we knew that we were going to augment. And we can release the periosteum to give us some additional volume to be able to pull this flap and mobilize the tissues to cover the enhanced volume. So now we have some options to think about. We can think about, well, do we now do a block graft in order to create sufficient bone for our implant? Or is it better to do a GBR procedure? And what membrane should we use and what kind of bone substitute material? Is it autogenous bone the gold standard, as we often hear said? Is that actually true? And when should we place the implant? Should it be placed now? Should it be placed later? This tends to be just something that's rather subjective rather than having any kind of rationale. But let me try and see what we can find out from our experience and from whatever literature there is, which isn't a great deal in terms of looking at aesthetics. And of course, one of the useful papers that we have from Jent and Lecombe was this study about exactly this, looking at single-tooth implants where block grafting had been done and looking at the implications of that treatment. And their conclusions were that the the block graft was very useful to provide sufficient bone for placement of the implant. However, there was significant variations in the resorption pattern of that graft over time, which made it very unpredictable and had a big impact on the aesthetic outcome. You know, of course, if you look at the studies, the success and survival rate of the implant is fine, but if it doesn't actually create the aesthetic outcome that we want, then really in the aesthetic zone it is a failure, but it wouldn't be considered so in a scientific study. And so we don't have much data on this sort of stuff. And if we look at a case that we can see here, it's one of my own cases. You can see we treated this case 12 or 13 years ago, and we see the patient with a block graft, implant placed, everything looked pretty good, final result was nice, but after 4 years we see some significant volume loss of tissues and bone. We can see that perhaps our contours of our restoration were overly convex as well. That's something we would do differently today, but nevertheless we see that there isn't that stable and predictable outcome with this type of procedure. And so if it works for some of the patients some of the time, that's not really going to work in my practice. I want procedures that will work for most of the patients most of the time. Unfortunately, nothing works for everyone all the time. So we have to really try and up the predictability stakes for our treatments. Well, let's have a look at GBR. Well, again, not a lot to look at in terms of impacts on aesthetics. But one paper that was useful is from Becker's group, where they looked at the implications of autogenous bone grafting or membranes. And they found that, again, as highlighted in yellow, that they tend to have worse outcomes than compared to non-augmentation groups. That would make sense. If you have a stable healed ridge, then you place an implant in there and there's adequate bone for the implant support, then you're going to see less volume change. If you augment it with the material, then you want the purpose of the augmentation is not just to be able to place an implant, but also to maintain aesthetics. And of course, if you see reduction in that volume over time because you're not stable, then that can have a big impact on the aesthetics. So they found that these barrier membranes and autogenous graft did not appear to have improved stability of the crestal width of the ridge. So what was useful in more recent times, and of course many of us have been doing this for a long time and teaching it on lecture podia and clinical experience, but of course often the papers, research does take some time. Unfortunately, it's often the reverse, that the research takes time to follow up and catch up with clinical practice, as many of us have found over the years. But this is a useful paper because it looks at the fate of buccal extraction sockets of teeth with prominent roots, and from the Nevins group. And very interesting that you see how much volume is lost when you extract a tooth and do nothing in the top pictures of the cone beam CTs. And then when they grafted the sites with some bone substitute material, particularly anorganic bovine bone mineral, which maintains volume and tends to resorb, well, if it resorbs at all, it tends to resorb very slowly. But we know that it maintains its volume well. And they found that this was able to better maintain the volume of these extraction sockets. And so many of us have been using these materials. Indeed, those of you who have seen me lecture have heard me talking about this for many, many years. But we have now got some evidence to back it up, the whys and wherefores, of course. So What else has been interesting? Well, some other interesting papers that came from Japan actually was to demonstrate that when we have a certain thickness of soft tissue, it tends to be more stable. They actually come up with an idea of developing a height to width ratio, but I'm not a great lover of numbers because, you know, people are individuals, they don't always fall into boxes, and we can't always, you know, work by numbers. It helps us in terms of teaching and getting guidelines, but we have to always recognize that it is more to you know, dentistry is also an art, not just a science. But we see here that, you know, if you have thin tissue, where you have a height of tissue, it tends to recede and stabilize until it reaches a certain sort of proportion and dimension. In other words, it has to have a certain thickness. So not only do we need a sufficient height of tissue for our biology width, we need a certain thickness in order to maintain a stability over time. And that proportion wants to be about 1 to 1.5 millimeters, 1 to 1.5, sorry. So let's go back to our case. And the last question now is, when do we place the implant? Well, what we like to do is that we like to place the implant straight away. And the reason for that is, providing that we can get stability, and this is the key, we need to be able to have a stable implant. Providing we get good priority stability, we want to place our implant straight away. What that does is this. Think about it. If we look at all the work on bone grafting, we know whatever materials that we use, even with these bone substitute materials, we will always see some shrinkage. And, you know, in the best case scenario, we're looking at, let's say, about 20% of volume loss. We know in some cases with autogenous bone, and those of us that have worked with hip grafts and so on have seen much more than that over time. But that's a different subject. And larger cases are a different issue and are much more complex, of course. But if we're looking at a localized bone graft, we know that we lose about 20%. Now, if in this case, for example, we were to place a block graft or a GBR procedure with bone, and we're going to lose 20% of, let's say, 1.5 or cubic centimeters. Let's say, for the sake of argument, in this case, we have a cubic centimeter and we lose 20% of that volume. We lose essentially 2 millimeters of facial volume, if you like. And that's quite significant in the aesthetic zone. If I, however, place my implant into that site, I only really need 2 millimeters of bone facial to that implant, or thereabouts. And if we lose 20% of that, that's only 0.4 of a millimeter. That really has no clinical significance. And we can see that that then gives us a much better outcome. So that's the way we think when we manage these cases. So here we go. We can see the steps through the surgery of this patient. Placing our implant in the ideal three-dimensional position, 3 millimeters apical, 2 millimeters palatal to the final gingival margin. You can see a lot of the threads are exposed. We tend to bring some scrapings of autogenous bone from the apical aspects of the site that we're working on. You may not really have to do this. Some of the literature recently suggests it's not necessary, but it makes me feel better just to bring perhaps some cells and blood and some, you know, building blocks of new bone directly in contact with the implant surface. We then cover this with our bone substitute material, our anorganic bovine bone mineral, and then we cover that with a resorbable collagen membrane. We use 1 or 2 sheets simply because there's plenty in the box, and rather than waste it, we put 2 sheets on there. It gives us a little bit more volume, perhaps. I'm not sure that it has any effect on the regeneration capacity, but it seems to work pretty effectively. You can use a non-resorbable membrane if that's your preference. I don't think I have a strong view on this. I think the resorbable membrane is simpler, less likely for complications, and works in my hands effectively. And then let's see a quick look at a video of the actual surgery here. I don't think we need the sound, so let's kill that. Okay, so we can see we like to, in a separate case, it's a lateral incisor that was referred recently. We can see there's a concavity, there's a defect, but I know from the referring dentist that this is a narrow defect, and it's a lateral incisor, which is rather an easier tooth to do. So a sulcular incision which maintains the papilla from the palatal aspect. In other words, we keep the blood supply to the papilla. We know that the papilla will rebound, but if we don't lift it, then we reduce that initial loss, and it maintains, it makes it just a little bit more easy to manage and a quicker result. We take our vertical releasing incision distally, just because we know we're going to augment the volume, and therefore we want to be able to move our flap coronally. And you can see me just very carefully just removing any tags or granulation tissue which are holding the flap, releasing the flap to enable me to elevate it adequately. And then we remove any granulation tissue, so we're down to clean bone. You can see me now just releasing the periosteum so that I can mobilize the flap effectively. And we just do that carefully now, and now just continue to mobilize and prepare our flap. And we pay attention in detail. One of the advantages of doing your periosteal releasing incision early in the procedure is that, of course, that you create the bleeding at the early part of the procedure rather than just before you close, and then you may get less of a swelling and bruising for the patient. When we go ahead and place our implant according to standard protocols, you can see us just preparing the osteotomy here. You can see that we're going to have a significant dehiscence on the facial aspect of this implant, and we're just checking the site. We go ahead now and place our implant into this site, as you can just see us preparing now, and according to this protocols today, which are to place the implant dry, and we go ahead and do that. And of course, once we've got the implant in position, I sometimes like to also use a hand instrument just to manipulate the position of the implant to get it just correct from my perspective, mesodistally and buccolingually, make sure the orientation is just where I want it, and also just to get a feel for the stability and the torque that we have there. So once we're happy with the position of our implant, we can go ahead and start to just elevate the flap a little higher to access a little bit of the apical bone. We can just scrape that very conveniently and easily with a malt curette or a bone scraper, and we start to cover the exposed threads with just some cells and some blood and some tissues, hopefully a few things in direct contact with that surface to initiate our integration and our healing. We're going to do this as a one-stage procedure because it's a simple case, and we're going to have a transmucosal healing here. So there you can see us with our healing abutment now in place, a narrow healing abutment, obviously a narrow implant for a lateral incisor too. And we place our bone substitute material now in place to create our volume. And this material is there to support volume, not necessarily all becoming bone, but that doesn't really concern me as much because we want to maintain the volume of the tissue and have a stable architecture. That's our real challenge. So we remove the excess, and we're going to then just shape that up and place our resorbable membrane in place over that graft now. So having trimmed that to the appropriate shape beforehand, we just place that in place and wet it with a little bit of saline. It helps to actually just manage it very carefully. Just position that in the right place, and you can see us now just clearing away any excess graft material, and very carefully to remove that without sucking the membrane, of course. And you can see us managing that. And then we tend to use a second piece of the membrane just simply because there tends to be a lot left over, and it just helps to give us a little bit more volume and stabilize the graft a little better. But you don't probably need to even do this step. See, it's just wetting it to stabilize it. And then it's important to trim the membrane appropriately so it's not touching the adjacent teeth, and that we don't have any chance of contamination of the graft by bacteria ingressing through the sulcus. So you'll just see the video as we trim the membrane to the appropriate shape, and using some curved scissors is an easy way to do this. And it's important at this stage just to pay attention to detail, because the attention to detail at the surgical stage will make your life at the prosthetic stage a lot easier. So then we can just take our flap now, and we see that we can cover this quite nicely. And we're going to take this tissue which sits on the occlusal aspect of the ridge, in other words where the implant is now, and we take the epithelium away from this. And then we're going to release that tissue, because we have a nice thickness of about 3 or 4 millimeters of tissue there, which we can now utilize to help us to create our buccal volume of tissue. If we don't have sufficient thickness here, we could consider doing a connective tissue graft from the palate also. But sometimes we've got enough volume and we can just simply release that little tissue, and you can see as we just rotate and tuck it back inside underneath itself on the labial, and then that's going to sit facial to the healing abutment and give us that thickness of tissue that we need for that biologic seal. And then using our microsutures, today we tend to use monofilament polypropylene sutures of 6.0 or 7.0, very fine to get a very precise adaptation of our flaps. And as we continue, you can see some of the references of full use of these biomaterials, which we have on the literature, which show that that these work very well and do indeed maintain their stability and volume over time. And there's a couple of references for you to look up. So then we pay attention to detail, suturing this flap very carefully. I'll just let you spend a little time to see how we can suture, and you see how nicely the flap adapts together. And just taking time to really precisely position all the tissues where you want them to be, so that we can end up with a nice outcome and a nice result. So as you see us doing that, we can get a pretty nice result there. So let's move on. So we go back to our case, and now we can see our case here is in the patient that we were dealing with before, and you can see we've done a two-stage surgery here. We buried the graft because initially we needed to build quite a significant volume of bone, so we placed our implant, did our bone graft, and we've covered that, and we do that as a first stage, because if we then try and also augment the soft tissue volume, we may end up with not being able to really get good closure and passive closure of the flap. So we tend to treat these cases in two stages. Initially to create the bone, and then to come back and do the soft tissue at a later stage. The first stage, create the bone volume, and now we come back after 6 months, do a second flap like the one I showed you in the video, maintain the papilla, as you can see in the third slide or fourth slide there on the top, and we then are going to augment our thickness of tissue, because we only have about 1 or 2 millimeters of tissue, and of course if we place our transmucosal component, we will get recession to create the biologic seal. So we don't want to do that. We want to enhance our tissue thickness so that we have as much tissue, or maybe slightly more tissue than we need at the start of our uncovering of the implant on our transmucosal component connection. So here we have a simple connective tissue graft taken from the palate, which is sutured into place with resorbable sutures onto the underlying periosteum. There's a split thickness dissection of the tissues underneath, and you can see us placing the healing abutment, and now the flap is replaced into place. And we took a rather broader flap than we needed to in this case, because just in case the graft hadn't worked, we wanted to check it out and to evaluate it, but we could see that it worked very nicely indeed. And we replace our rochette, and you can see the narrow component and a narrow impression coat being utilized at this stage, and this is important. And then we design our abutment, because of course a tooth looks like this, but our implant to abutment is different. It's not like in the old days where we used to have these divergent components. Now we want to have narrow, concave, transmucosal components, and then late flaring to the shape of the tooth to create our emergence profile. This maximizes the volume of tissue by keeping the components narrow in the apical region and transmucosal area. We want to support our papillae, of course. So it's important to get that right. So now we place our abutment in place, and we can customize that chair side. Maybe we need to just reduce a little bit of the volume labially to create enough support for our soft tissue, so we don't want too much blanching of the tissue, if any. And maybe we want a bit more support on the proximals, so we can have the lab just add a little bit of ceramic to that or modify it. And an easy way of doing it is to try and the resin dye of the not the dye, the resin that they scan before they send it off. If you try that in a resin abutment, and then you can modify that and then have them scan it to the precise shape that you want. Provisional crown can be cemented at the stage, and we tend to have this little under contour on the labial, just and a little bulge where the cement enamel junction would be. Perhaps we don't go as deep as this one now. Today we'd go more shallow, but you can see the crown in place, and we want now for maturation to occur on the final crown as we allow time to go. So Remember what the literature says, that we should see 1 millimetre to 1.5 millimetres of facial recession. But here we have this patient now, difficult case, not an easy case, thin biotype, large defect, prominent root architecture, and yet in 6 months we've now seen some coronal migration of tissue. You can see a little creep of tissue on the labial of the implant. And if we look at the same patient now 5 years later, we can see that we have absolute stability of the labial tissues around this. And in fact, maybe it's a little bit too coronal at the end of the day. The papillae are where we expected, slightly deficient on the mesial and distal because of the triangular nature of the teeth and the contact area. If we wanted to change that, we'd have to take the contact higher, and then we could probably fill that space too, but the patient didn't want to do any of that. We've also done a little bit of composite on the central incisors, you can see, to mend that fracture, and that you can do with a little bit of a polish up now after 5 years, as you can see. What's interesting is I see the stable bone as well. So in summary then, if we can just summarize that, what we're trying to do is create a stable bone volume and architecture to have the sufficient soft tissue thickness and volume so that we don't create a need for bone remodeling to occur at the time that we place our transmucosal components, to have narrow components, and then to place our abutment and take a final impression of our abutment in situ once we've shaped the tissues of our temporaries. In other words, that the abutment stays in once it's placed, and we take a simple crown and bridge impression of that abutment with a cord and a standard impression technique that we would do to make a crown on a tooth. And then that is where we make our final crown, and the abutment is staying in it from the start. So, in other words, by managing all these aspects, we are trying to optimize the stability of the tissue complex around our implant restorations.